That's great. So, welcome everybody. My name is David Heath. I'm a non-executive director for public participation and engagement at the CCG. Really good to see so many people here this evening. Just to let you know, you'll already have seen it, I think, but the session is being recorded and it'll be made publicly available on our website after the event. What this is about this evening, it's, I hope, not too formal, but it's about restarting the conversation that we effectively had to pause back in April 2020 when, for obvious reasons, everything ground to a halt for a while. So over the next hour, what we're going to do is to share the findings from our initial engagement, tell you about the actions we've taken following the feedback, and talk through the next steps in this work to make sure that we get the right services delivered in the community in the way that people feel comfortable with. And there'll be an opportunity to ask questions. I hope at least half the session will be actually dealing with questions rather than us talking to you. So you've got the opportunity to type questions into the chat bar and we'll come to them. If you're really having problems, then we'll try and find another way of letting you in as soon as possible. And if there are any questions that we don't reach, we'll come back to you as quickly as possible after the event. Can you please keep your microphones on mute during the session throughout, unless we actually specifically ask you to come on. And again, many thanks for coming along and supporting the development of health and care services in Somerset. It's a really important job that we're doing this evening. So without further ado, that's enough from me. I'll come back a little bit later, but I'll ask Alex Murray and Maria Hurd, who are going to take us through this presentation, to introduce themselves. Should we start with Alex?
Hello everyone, and again, thank you for coming this evening. I'm Alex Murray, I'm a GP and I'm Clinical Director at Somerset CCG.
And Maria.
Hi, I'm Maria Hurd. I'm Programme Director for Fit for My Future. I'm a nurse by background and work alongside Alex.
Thank you very much. So I think, Alex, you're kicking us off?
I am indeed. So if we can go to the next slide, please. Thank you. So people may remember back in April 2018, we kicked off Fit for My Future. Now, Fit for My Future is Somerset's health and care strategy that aims to support the health and wellbeing of Somerset by changing the way we plan, buy and provide services in Somerset. It's a joint strategy led by Somerset County Council and Somerset CCG in collaboration with our partners across the NHS, social care, the voluntary sector and volunteers in the public, clearly. And it's to drive the Somerset vision, which you can see on the slide in front of you. What this means is that for the people of Somerset, we will provide a different model of care based within their community as close to home as we're able to achieve, that's safe, effective, equitable and sustainable. This means that no matter where people live in Somerset, we will enable people to live healthy, independent lives, to prevent the onset of avoidable illness and support active self-management. Ensure safe, sustainable, effective, high quality, person-centred support in the most appropriate setting. Provide support in neighbourhood areas with an emphasis on self-management and prevention. Absolutely value all people alike, address inequalities and give equal priority to physical and mental health. And improve outcomes for people through personalised, coordinated support. We want everyone to live healthier, independent lives for longer, but we can't do this alone. And together we're working to build a health and care service that's fit for our future. As we move into a newly formed ICS, we plan to transform our out-of-hospital care beyond the traditional primary and secondary care divisions. We want to redesign community-based services in their broadest sense, enabling voluntary sector organisations and the population themselves to define the way we work in the future. We want to blur the boundaries across mental and physical health, across prevention, early intervention, primary, secondary care, working on the basis that your bed is always the best bed. We want to enable care to be delivered as close as home as possible by the right person at the right time and in the right place, but ensuring that high quality, safe and sustainable care is not just provided within our community, but within our acute trusts whenever those services are required. So over the last couple of years, we've developed 4 work streams, focusing on mental health services, community health and care services, acute services, and prevention and early intervention. And today we're focusing on the community health and care services work stream. We can go on to the next slide and I'll hand to Maria.
Thank you. So last year, between January and April, we shared our early thinking about how we could improve health and care services in the community. And we sought your views on these. And that's what we're sharing this evening in terms of what you told us. As David said, the COVID pandemic paused our activity. And so hence you've not heard from us for a while. But we thought it was important to share what we heard as we pick up the programme of work again. One of the things we heard loud and clear was the value you placed on community hospitals. And during the summer, we've spent some time developing our vision for community hospitals and how they contribute to delivering the overall vision for Somerset that Alex spoke about. We're sharing this more widely and we'll give you details on how to get involved later. In early December, we'll be identifying solutions to the role each community hospital plays in delivering the vision for community hospitals. And we'll work with local communities to inform each stage of our thinking in line with our legal duties. And if we need to make any changes, major changes to our hospitals, we expect to undertake a formal consultation on these proposals. We can't do it without you. To help us get this right, it's important to hear from a range of voices, from those who use community services to those likely to suffer health inequalities. By continuing to join the conversations with us and sharing your feedback, we can better understand your experiences and any challenges you face, so we can work together to develop solutions which are right for Somerset. I'm going to hand over to Alex to give us a reminder of what we were talking about last year.
Thanks, Maria. So hopefully people will recognise this model at least vaguely from last year. As everything, it's been updated slightly since then. Here we go from level 0 to level 4. We now talk about level 1 to level 5, but the basics are the same. And what we're doing now is working through these, and several of these now have been, I suppose, escalated or begun to be inputs during the COVID pandemic. So we start off with level 0 on here, which is living well. So those are the things that we do for ourselves to look after ourselves. That doesn't really need any input from anybody else, but actually it's helpful sometimes to have information or availability of services to support them. At level 1, it's about I need some help, information, advice, but I don't actually need to see a doctor or a nurse or a social care worker. Actually, it's about how I can access support within my community from the services that are available to me. And that could be Mind, it could be the Alzheimer's Society, it could be Weight Watchers or Slimming World. It's those systems that I have available to me that I can use to support my own well-being and my own way forward with my health and care. At the next level, it's about getting some help. So this is really when we have an issue and whatever we've done up to now hasn't worked, or we don't know what to do next. So this is around primary care, and this is where primary care sits as the bedrock of the NHS, as that first point of contact for the majority of people. But actually it talks about other services as well that will be delivered at home or within your locality, within your neighbourhood. So for example, rapid response, which has been escalated during the pandemic dramatically to ensure that people can stay home if possible with the right care and support to enable them to not need to go into an acute trust unless absolutely necessary. It's about district nursing, which clearly people might be aware of in terms of dressings and care at home, but it's also about things like intermediate care, where we can get people out again from hospital as quickly as possible with the right care and support based within their own homes and getting them back to their families and where they want to be as quickly and as safely as possible. At level 3, it's about I need something more than this. I've seen my GP, actually I need to have a scan, I need to have a specialist referral, but it's a one-off attendance. So whether that's through an ultrasound appointment or whether that's going to my outpatients clinic, I will then return back to my home and to the care that I'm receiving within my community. And finally, we have level 4 as it is on here, which is like inpatient and emergency care. And that's really care that requires multiple specialist input or significant resources to manage that care. On here, we clearly have intensive care, accident, emergency, but it also includes specialist rehabilitation after stroke or a brain injury, where actually what we need is a group of specialists together working to support the outcome for that individual. Go to the next slide, please. And at the same time, we talked about same-day urgent care. And again, this is something that we've been developing since we came out to engage back in 2020. What you can see here is this idea of talk before you walk. So the really important aspect is that actually you don't just pitch up to emergency departments or to the MIU if you can. Actually, what you do is phone first, and that's either to primary care, Somerset Direct, And people have seen NHS 111 first over the last 12 months coming to the fore. Whereas if it's not an emergency, if it's not life-threatening, which would be 999, the idea is out of hours, in hours, 24 hours a day, you can contact NHS 111 first, and they will guide you to the right place to meet your needs. That might be self-care, it might be community pharmacy, might be appointment at your GP, or even an appointment in your local minor injury unit or emergency department. But actually they'll get you to the right place to meet your needs, rather than you sitting and waiting in a queue in a needy department or in MIU. The really important thing about this is at any time, if you have a life-threatening emergency, whether it's yourself that calls 999 or you speak to one of these other teams, they will direct you to get that urgent and emergency care support immediately if that's what's required. And that will take you clearly through to the A&E department or through to specialist centres if that's what's needed. It's really important to say that equally when people phone 999, this happens frequently when perhaps they don't have a life-threatening emergency, but they don't know where else to go. That again will be directed back through NHS 111 and back through the services, again to make sure they get to the right place to meet their needs in the right time. Next slide, please, and back to Maria.
Thank you, Alex. I thought it'd be helpful just to share how we went about planning for the engagement and the responses we got. So preparation is key, and we identified groups of individuals and organisations who may be affected by what we were talking about or have an interest in what we were speaking about. We developed a plan to get this message out, including sharing material at 214 venues across Somerset. We held 64 engagement events and workshops with seldom heard groups. At the end of that engagement period, we were required to stop face-to-face events because of the COVID pandemic from a public health perspective, and we switched to online events, and also the ability for people to continue commenting online. We had a good response overall, and thank you to all of those who took time to feed back to us. And what you're hearing tonight is a summary of the independent analysis of this feedback. We reviewed who we heard from. We know that we need to hear from a wider range of individuals in Somerset. Particularly, this includes men, and those under 55, families and other communities we are less likely to hear from. We recognise one of the reasons we didn't hear from these groups as much as we would have liked was that we asked people to come to us and didn't go out to seek views, and this restricted who we heard from. So we will address that when we go forward on future engagements or consultations. Potential equality impacts were identified relating to age, deprivation, disability, gender, and LGBTQ+. Again, we'll address these as we move forwards. So thinking about future engagements and consultations, we'll work with Spark Somerset and other voluntary and community sector partners to make sure we identify all those with an interest and have a plan to reach them. The overall response from those in support of our early thinking was that supporting at home can lead to better patient outcomes. If care was provided at home, it may mean that families and carers have to travel less. Urgent treatment centres may offer an enhanced range of services to take pressure off our accident and emergency departments. And we heard some concerns. Potential travel impacts for all, especially carers, elderly, and those with a disability. A perceived loss of access to local services. Worried that community hospitals may close. An ageing population that would struggle to travel further for urgent care. A concern that there were insufficient professionals to run a GP-led urgent care service. Potentially inadequate provision of community-based beds for those that require a hospital bed, and a rural geography with poor public transport provision. And I'm going to hand back to Alex.
So what we did was we sort of put some of these outcomes together so that we can look at themes and look at how do we manage those going forward. Some of them Maria has mentioned, but hopefully I'll go into slightly more detail. The first one is around health outcomes. So actually what happens to you as a patient? And I think the most important bit for me as a clinician is that patient outcomes were considered the most important factor overall. That's very much what we put at the centre of health and care in Somerset and have always done, and want to work towards improving those outcomes as a priority for all of our population. There was a concern that the health of carers can suffer when the provision of care at home is insufficient. And clearly what we've seen during the pandemic and what you see in the media every day at the moment is concerns around social care and the NHS in terms of the resources that are available and the staff that are available to manage those services. What we're doing now is piloting a carers engagement service, which will be an independent voice to help us better understand the needs of unpaid carers. But in an individual perspective, it's working with those carers and those patients themselves to understand what's required. And that's moved forward during the pandemic as we've moved into a greater what we call intermediate care service, where it's about trying to get people home and into the right place. There was lots of discussion about rural inequalities, rural exclusion, and that the risk of the health inequality gap, especially for older people, people living alone, or people with a disability. The idea of this whole programme is that the proposals to support care closer to home actually get those services out into local communities where people need them. So overall, the need to travel, the need to get into an urban centre will be less. And actually, we would hope that that will then begin to reduce any of those rural inequalities that we've seen historically. And finally, there were lots of concern about digital exclusion or the access to digital services, particularly when in Somerset, Wi-Fi isn't always as we would wish it to be across the county. There is separate work going on around digital outreach, both through health and social care, to try and ensure that people have the right access they need, but also working with the local primary care networks, so the groups of practices who understand their patient population, who understand the demographics, to ensure that we can provide the access that's required. Next slide, please. The next concern was about access to services, and firstly about access to emergency care and other hospital services if a patient was based at home rather than perhaps in a community hospital setting. It's really important to recognise that wherever you are in Somerset, you will still have access to emergency care. And actually, if we are caring for you at home rather than in a community hospital setting, you will already have those links in place with the services that are required. So actually, we can escalate much more rapidly than if you were home without these services available to you. There was concern about providing more support at home would increase waiting time for GP surgeries. Clearly, this is incredibly topical at the moment, and we all see in the media every day the issues around GP waiting times, around the access to face-to-face appointments. I'm a GP. I'll be the first to recognise that GP services are struggling at present, that they have increasing demand, but we are working really hard with all of our practice and our primary care networks to support GP surgeries. And clearly, this is part of our planning going forwards so that we can ensure that aspect of care is there in place sustainably for the future. There was lots of talk about access to care packages as an issue, particularly for older people who are long-term disabled, and the concerns about they might not reach that criteria for the level of support and what happens then. Again, work through the pandemic has been continuing through our intermediate care service to ensure that we have the right access to care packages, and that actually now, for example, if you're discharged, you might go home initially with even just a few days, just to make sure that actually you are okay and you've got the services you need, or we can increase them if that's what's required. So some of this, as I say, has already been taken into account, and we're working towards increasing that into the future. There was lots of concern around the community hospital beds themselves and how important they are for people perhaps in step down, end of life, respite, and a feeling that they were also there to relieve acute hospital pressures. I think we'd all agree that there is a need for beds within our community. I think the question comes down to how are those beds used, and where do we need them and how do we need them? So certainly for respite, end of life care, step down beds. But actually, there are multiple ways that we can do that through care homes, through residential homes, as well as community hospital beds. And it's about ensuring that we have the right beds for the right need for the population in our communities. At the same time, we believe that we can create more beds locally by providing rehabilitation through care homes and residential homes that are specifically resourced to provide that service to enable people ultimately to get back to their own home. Next slide, please. Travel, we're in Somerset. We're a rural county. Travel is always top of the list. Clearly, transport was a significant issue, particularly those who don't have their own cars or who would struggle to access public transport. And we know that public transport is an issue across Somerset. What we are doing is working specifically with a transport focus assessment group to look at the transport challenges across Somerset This has actually been running for a little while now, and it's working with various of the groups. And I noticed in the chat, there's a comment about grassroots community groups, and a lot of those work around transport and getting people to the right place. And it's about us bringing those together to understand how we can improve the challenges of transport. But again, coming back to the idea of providing care closer to home, based within people's neighbourhoods, within their localities, the need to move should be less. We shouldn't need you to travel to Musgrave Hospital or Yeovil District Hospital for as many specific services as we do currently. The second most important factor was travel time. And clearly for those areas that we have furthest away from our main acute trust, that's the biggest issue. So clearly Central Mendip, North Sedgemoor and West Somerset. Again, this is about looking to see how we provide those services closer to home, and also work with our partners across the borders, whether that's Western, whether that's the RUH in Bath, to ensure that people can receive the services that they need as close to where they need them as possible. But being mindful that clearly this is going to be an ongoing challenge as we work through this process into the future. Next slide, please.
Thank you, Alex. You suggested that clear signposting with an out-of-hours contact for home-based care was needed. This was really helpful feedback, and we'll look at how we provide that. You suggested that we explore the option of using care homes as a resource. And as Alex has said, this was part of the early thinking we shared with you, and something that we've been doing more frequently during the pandemic. And we'll build on the learning from the pandemic. You suggested a more holistic approach was needed, one that involves community resources, staff in the community, working with the NHS, with social care and voluntary sector, working closely together. That's what's been happening during COVID, and part of the work we're doing to develop what we're calling neighbourhood teams, where our different organisations work together. You asked us about affordability. You had concerns as to whether the proposed model was affordable. And we will undertake, as we develop potential solutions, we'll make sure that they are costed as they're developed. And we've got some learning again from the work that we've done during COVID to understand the true costs of providing more home-based care. You had some staff resource concerns. So you were concerned that there weren't enough suitably trained care staff to support people in their own homes. And since we last spoke last year, we've introduced nursing degrees, trainee posts and apprenticeships in Somerset, and are working hard across the system to think about the carers and the staff that we need in the care sector. You were concerned that staff would be stretched by travelling further between homes. So if they were having, and they would be disincentivised when they were not paid for travel time. And we recognise that. And we're looking at how we can minimise the impact of that. You had concerns that paid carers and community nursing staff currently struggle to give sufficient time when they visit people, and they visit infrequently. So you questioned how the resources would be provided to support more home-based care. We've learned more about this as we provided additional home care. And again, we'll take that learning into our next step of thinking. And you were concerned that this model would require a much higher level of staff to operate successfully. And we understand that concern, and that's part of our thinking going forward. You had some concerns about patient choice and suitability of home care for everyone. You told us that not everyone's home situation was suitable for care at home, and choice should be maintained. Decisions will always and continue to be made according to individual needs and circumstances of the patient. That's important now as it is in the future. And finally, but probably most importantly for me, it's continuity of care and seeing a familiar face. And that will continue to be an important consideration as we move forward. So the feedback we've shared with you is an important part of a much wider programme of work to improve services delivered in the community. We're working in partnership with Somerset Foundation Trust and colleagues from Adult Social Care and the local authority, who in developing our thinking. In partnership with Somerset Foundation Trust, who are responsible for running our community hospitals, we're developing the vision for community hospitals and how they contribute to the overall vision for Somerset. This work has started with initial workshops taking place during the summer, and we're holding some further workshops in September, details of which are on the Fit for My Future website, and one of my colleagues will post the link into the chat. We also have a survey open, which we invite you to take part in. It's an opportunity to comment on the work that's been done by stakeholders from across the system on the development of a community hospital vision and how we create them as a real asset in the community. Again, details of which can be found on the Fit for My Future website. All of the feedback will inform our ongoing proposals for developing services delivered in the community in Somerset. Thank you.
Well, thank you very much for that, Maria and Alex. We're going to move to questions now, and this is your opportunity to ask any questions you want, and we'll get through as many as we possibly can. There's already a few questions on the chat line. One of them I'm going to actually answer myself, which is, will it be possible to see a recording of this later? And the answer is yes. It will be on our website, and as soon as we can put it up later, and that means you'll be able to go through the slides with a little bit more care than obviously you can when they're just flashing up. If anyone wants a set of the slides sent to them, I'm sure we can manage that as well, so you only got to let us know. So I'm going to just go through the questions one by, well, not necessarily one by one. I'll take first two together. Albert Owen says, are you working in collaboration? Are you working, meaning CCG, working in collaboration with the work being carried out by the Somerset NHS Foundation Trust? And Nigel Lengert says, the role of social workers in this model, children and adult services, is anyone from SCC present this evening? So it's about collaboration, how we're working with our colleagues in the system. Maria, is that something you'd like to answer?
Yes, so the answer to are we working in collaboration? Absolutely. This is part of a health and care strategy which is being developed by ourselves in the CCG, Somerset County Council, along with colleagues at Somerset Foundation Trust and Yeovil District Hospital, as well as partners in voluntary sector organisations. So the work that you'll see being undertaken by Somerset Foundation Trust is absolutely supported by us, and we are part of that work. It forms part of the bigger picture. In terms of working with adult social care and children's social care, yes, we're working with them. I'm not sure if anyone is present on this call, but absolutely, yes, we're working with them, and they have been an equal partner in terms of the work that we're doing to develop integrated care services. And Alex probably is most closely aligned to that work during the pandemic. So Alex, I don't know if there's anything you want to add.
Yeah, I mean, I guess I need to reiterate what you just said, Maria. I think it's really important to recognise that whilst you'll see different people presenting at different things. So if you look at the recent community hospital workshops and the ones that are continuing, you'll see Lucy Knight there rather than perhaps myself and Maria. But I think it's important to know that we're sitting in the background, and actually what we're doing is working collaboratively across the system. So we're enabling the people who lead the different services to lead some of that work around it, which is really important because clearly they know their services better than anybody. And the same goes with both adult and children's social care. So as part of this, the directors of adult and children's social care, I speak with certainly on a weekly basis and probably more often than that. So whilst they're not in the room this evening, actually they are intimately involved in the work we're doing forwards. And I guess just picking up, there was another question in the chat around children. Some of the work back in last year, 2020, was very focused around adults because it was looking at community hospitals and how we manage that. And clearly a lot of our community hospitals, particularly inpatient beds, are used by adults and older adults. But it's really important to say that one of the pieces of work that is happening now is that work around children and young people, and how do we ensure that the services in our communities care for them in the right way and support them in the right way they need to move forward in their lives in the way they would want to. It's just that I guess there's a progression through the work as we go forward, depending on the immediate focus at the time.
I think it's one of the most encouraging things over the last year or so, really, is the degree of co-working that we have established with the other partners in the health system and with the county council. I think it's a marked improvement, if I may say so, from previous years, and that will have to accelerate still more as we move towards this integrated care system model, which is now going to be the norm across the country. So I think that there is a lot of optimism that actually the system as a whole will be working in a much more collaborative way than perhaps it has done at some stages in the past. We've got another question here about working with others. That's from Justin Sargent. The charities mentioned are well-known brands with a clear health slant. All good organisations, but quite sizable and professional, delivering recognisable services. Where's the recognition of the thousands of informal and grassroots community groups that contribute to well-being, even if they don't identify as health providers or feel they are delivering services, just doing good stuff? Who'd like to pick that up?
I'm happy to.
Alex.
Start,
please.
and then Maria, you can add, or Emily possibly. So absolutely, Justin, and I guess it's probably worth saying in my other hat, I've been working through the mass vaccination for COVID over the last 12 months. That's why I've not been focused quite so much on Fit for My Future. And I think what's come to the fore is exactly as you say, is the number of smaller organisations, the number of volunteers that are out there and are doing amazing work across our communities. And so one of the things that we've learned, I guess, through the COVID vaccination, and we knew it before, but we've become much better at it, is how do we engage with those smaller organisations? How do we enable everybody to have a voice in this and to be able to, I guess, almost to showcase what they're doing so that we can learn from it and bring it into our thinking. And that's one of those things that's been happening. You know, I think it's fair to say health and social care have learned a lot through the COVID pandemic. Clearly, we would have rather wished we learned it in a different way, but certainly working with our volunteer groups and the smaller VCSE organisations has been absolutely one of them. So yeah, I can reassure you that is without doubt part of our aim and building on the work that we've had over the last year.
Thank you, Alex. And I think the other thing I'd add is, which Emily may also add in, is that we've recognised the need to reach out to smaller organisations or community groups. We're investing some money into developing that. So Spark Somerset are the infrastructure charity in Somerset, and together with the local authority, we're working with them to make sure that we reach out to the many organisations. I think one of the things I love about Somerset is our voluntary sector is so diverse. We have got presence of some of the bigger charities, but actually most of it has grown up from local need and local recognition of issues and problems. So we're absolutely investing in how we work with them. So more news on that in the next few months.
Thank you. Now I can see Caroline is waving. I'll come back to you a little bit later. Caroline, wave again if I don't, because it simply means I've forgotten, and I'm sorry about that. These virtual meetings are an awful lot more difficult to chair, I have to tell you, than a public meeting where you can actually see somebody in the room. But nevertheless, we'll do our best. I think we've probably touched on Claire David's comment about what about young people, and hopefully that, although there was a question which I'm just searching for at the moment about whether Jane Nicklin, care homes aren't always the best site for all people requiring rehab. For example, young adults and working age people. We need to broaden thinking around venues to acknowledge this. And Mike Stanton has added even older people are uncomfortable with a care home bed in place of a community hospital bed. I think that's probably Alex again, if you would, Alex.
Yeah, that's fine. And I think there's a couple of things there. Absolutely, when it comes to younger people or people of working age. And one of the things we've talked about is the specialist rehabilitation centre. So places for people who had a brain injury, perhaps they've had a road traffic accident, are separate. They're not based within care homes currently. There are separate units that do that and then enable people to get home from there with the appropriate support. Clearly, there are occasions where younger people need long-term residential care, and that's one of those things that we need to think through, because clearly many wouldn't want to be within an older person's residential home. But for those specialist conditions, we already have specialist sites. I think the comment about being uncomfortable with a care home bed in place of a community hospital bed is really interesting, and I think that's partly our history, where we come from, and just that perception of what it is like being in a care home or a residential home. When we're talking about this and we're talking about rehabilitation in these care homes, they are being specifically resourced to manage that, even down to the rooms, so that you've got an ensuite room, so that actually somebody who's coming out and was going to need to go home can get up and go to the bathroom themselves, can get up and make a cup of tea, can do those things that they're going to need to be able to do when they get home. And actually our community hospitals, you're not able to do that. You're not able to go and make your own cup of tea or practice carrying a tray with your sandwich and your cup of tea on back to your bed because of health and safety regulations. So there is something about how we talk about these beds, so that actually we're ensuring that people understand the benefit they will receive by not being in a community hospital, actually. And we've got evidence to show that people rehabilitation in those specific care homes actually have better outcomes and get home quicker. So there is something about how do we change that conversation? How do we help people to understand what the benefit is for people in very specific circumstances?
Thank you. Now, I've got one more that came through before we finish the presentation, I think, which is Trina Bright's. I'm concerned as to whether the support from district nurses to deliver training to colleagues when being asked to carry out a delegated nursing task. So I think that's about the demands on the time of district nurses and whether they can sensibly do both of those tasks at the same time. Don't know who'd like to pick up that.
Do I take that? So I think it's fair to say our district nursing colleagues work incredibly hard. And one of the things we're looking to do is upskill people. That there's work which whilst we didn't talk about it through the engagement as such, it's certainly work that we're looking at now, where actually you upskill a range of people to do similar jobs, so that actually you don't have somebody going in to do a blood pressure and then somebody else to do a blood test and somebody else to do something else. And it's how do we upskill the population? But the ask won't be on the district nurses to provide that training. That training is bespoke. It's for those services that are required. There may be some shadowing required, because actually, you know, there's a comment about continuity of care. People like to know who are coming to see them. But certainly we won't be asking the district nurses to deliver all that training, although there may be some shadowing that we'll ask to help people get out onto the road themselves.
Right, I'm moving on to some that have come up more recently. And Caroline, I haven't forgotten you. Some people aren't going to be able to use the chat line for various reasons to do with their computers. So if you want to ask a question and you just can't do it on the chat, I'd prefer you to do it on the chat, but do wave frantically, and I will, I hope, come to you. But I'm going to do one now from Anne Reid, which is, how are you going to ensure there is sufficient funding for GP practices? As I know, as Alex said, many are struggling or even going under.
So the issue with GP, I'm going to take that, sorry. Giving GP in the room, I figure that's probably quite sensible.
Alex, you were mentioned in the question, so I think it's perfect.
I think that's fair. Yeah, so to be honest, the issue with GP practice isn't so much the funding, it's the struggle with workforce currently. And we know that nationally there's a shortage of GPs, nationally there's a shortage of primary care staff. What we have got there is funding for what's called the reimbursable scheme. And this is about additional workforce that we can recruit into primary care. And in fact, we've recruited a whole range over the last few months. And this is around paramedics, it's around physios, it's around health coaches and other practitioners who can support GPs to do the work that they need to do, and actually lets the GP work, I'm going to say at the top of their license, so that the GPs can actually see the people that they're trained to see, the more complex people with severe mental health issues, people with chronic medical conditions. And so it's about how we manage that workforce and enable GPs to do their job, but support them around them. But I have to be honest, it's really not the funding that's the issue currently. It's more about getting those people into work around the practices, and that we're being very successful in over the last few months. But there is a significant push. Some of it did get delayed, as everything did during COVID, and we're just picking up those rates currently. But the hope is that that will actually give us that workforce we need and improve our primary care services across the county and maintain that access and sustainability into the future.
Thank you, Alex. I'm going to take now one from Paul Robertson. Where are social housing providers integrated with the home-based services? Maria.
Thank you, David. So I think on an individual patient by patient basis, you know, that part of the discharge is looking at are the settings suitable and we're working with social housing providers on an individual basis. But I think we're starting to recognise the value of sort of the housing element. So we know that if people are, in terms of the social determinants of health, if someone becomes unwell, actually the biggest impact are things like housing, education, the environment they live in. So we're starting to recognise the value of our colleagues in housing and working with them. But I think there is definitely more work we can do in there.
Thank you. Caroline, do you want to ask your question? If you unmute yourself a moment.
Yes, thank you. I can never work the chat bit. One question is, how does this fit with ICS? Because it sounds to me as you're doing exactly the same thing as they've been trying to do or intending to do. But at the same time, I do want to welcome more care about unpaid carers, because if you're shooting people out of hospital earlier than normal, they are going to need support. And that includes breaks, because 75% of carers, according to Carers UK, during COVID, had no break at all in the 18 months or 2 years that it's been. So that's really unsustainable.
Thank you very much, Caroline. So I'll ask somebody to answer the question about the breaks, which I think is incredibly important, as you say. As far as the ICS is concerned, I mean, this is one and the same, really. We're very lucky that we were working on this in advance of the announcement of the ICS, the Integrated Care Systems, but all the same players are in the room, all the same players are talking about the same things. So the one will merge, I hope, seamlessly into the other. It isn't a duplication or people in different rooms thinking different things. It's the same people in the same room thinking the same thing. So I hope that reassures you on that. In terms of respite and breaks for carers, who would like to deal with that? Maria, could you?
If I'm honest, I'm not sure how to answer that one. I absolutely recognise the pressure that carers have been under during COVID, and we need to consider that going forward. I don't know what the answer is, and Alex, I don't know if there have been any discussions that you've been involved in.
Yeah, so it is, I guess it's first thing, it's something we're really aware of. And as you say, Caroline, carers have been under huge pressure during COVID, that even the normal breaks that they would have had, the normal sitters they would have had who could come in and just give people an hour to go and get a cup of tea somewhere else, clearly hasn't happened. And we're really aware that there are a lot of carers out there now who are really struggling. There is work going on through social care. And one of the things we're looking at as part of the development of our neighbourhood teams is bringing together all the specialities, so whether that's GPs, whether that's district nursing, whether that's social care, so that we can begin to get a picture of those people who are at home and their carers who are around them, so who is struggling, and look at how do we get that support into those homes for those people as quickly as possible by creating that sort of rounded team around the individual and their carers. But that comes as part of the neighbourhood work that we're talking around within this. It's still very early days, and clearly the COVID restrictions are only just lifting in some of these things. So there has been a bit of a challenge around getting some of this to happen. But we have got one teams and we have got some of these groups working really well in some of our localities, and they're developing across the county.
Thank you. I'm becoming increasingly aware we're not going to finish all of this list of questions, which is always the case with these things. But can I promise you that you will get a reply as a result of having put your questions on chat? And it doesn't mean to say your question is in any way devalued if we don't reach it by the end of the time frame. And talking about time frames, I've got a question from Oliver Parsentini saying, what are the time frames for implementing your good ideas? Will this be spread over a parliamentary term or sooner? Maria.
Yes, so timeframe's a really interesting one. And actually, you know, we've talked throughout the presentation that some of the learning we've had from COVID. So, you know, we haven't stopped during COVID, and we've actually started to implement some of what we were talking about, and we'll continue to refine that. We haven't yet got a fully, you know, worked up programme of work to think about when you will see changes come through. But it's our, you know, it's our intention to to deliver improvements as quickly as we can, and is practical to have.
Thank you. Norman Cavill, where do digital visits fit in as part of future nursing care, especially for rural areas? Rural areas is a big issue for us in Somerset, as everyone appreciates. Alex?
Yeah, so there's already work going on currently looking at how do we use technology, I suppose, to help some of those observations and monitoring. Clearly, there are some things that need to be done face to face, and that's just health and care. But when we think about things like blood pressure monitoring, when we're thinking currently, we've got a process for COVID at home, the way we can measure people's oxygen saturations and understand whether we need to do something more or whether they're going okay. So those things are currently being rolled out. There's work around hypertension and other areas. So it is a progress. It requires the technology to be there and clearly requires the support services to sit behind them. But that is something that we're extending as we speak across a whole range of specialities, and we'll see more of that in the future. But I want to hasten to add that there will always be some things that we need to do face to face. And so digital technology will never remove that. It will just aid us in terms of how we care for people and how people can care for themselves.
Thank you. Jeff Brown's done a very useful advert for Spark. So everyone can follow that up by going to the website. Fiona Davis, you mentioned prevention. What will this look like? I think prevention is a key part of this whole program, but can we put some flesh on that? Sorry, Alex. I was going to say.
Sorry. So yes, prevention is incredibly important, and I know there's been lots of challenge historically because it's something that we've talked about, and it's difficult to evidence. Actually, what we've got happening at the moment are several work streams around prevention, very specifically. One looking at hypertension, so high blood pressure, and how we support people. How do we get people to manage their own blood pressure, to recognise when that might be high or low, and to get intervention. We're looking at healthy weight and getting things out into the community, and using, and working with a lot of those voluntary sector agencies, Spark and others, SASP in particular, to get some of these services out in communities that people can access whenever they want to within their house without actually needing to come through a GP or a health and care professional. A lot of this is kicking off, and again, unfortunately, COVID did put a bit of a pause on some of this work because actually, clearly, we couldn't get out and about into communities. But that's just starting off again as we speak now, and I'm really pleased to say that we've now got funding that's allocated specifically to the prevention work stream, so that we can actually begin to develop this work over the years that come, because ultimately, that's going to be the way we improve people's health and care going forward.
The organisational one here. What will the role of PCNs, that's primary care networks, that's the groupings of GP practices, be, and how will you encourage GPs to take more of a system view? Maria.
Well, I was going to say Alex might.
Or Alex. Oh, well, Alex works directly with the PCNs. You work with the system as a whole. Whichever. Alex, how about you then?
Yeah, well, that's fine. So yes, I do work directly with all of the PCNs and with primary care, and I think primary care is an amazing system, and it does form the bedrock of our NHS. But historically, primary care has been primary care, and we've seen, and everybody will know, the sort of divide that there's been between primary care and secondary care and social care, and then the rest of the system. Actually, the one thing integrated care systems are doing are bringing us all together much more effectively, building on the work that we've seen through Fit for My Future and actually through the COVID pandemic. So, even this week, I've had conversations with 2 primary care networks in particular in Somerset around how do we look at system solutions to some of the challenges they're facing, whether that be around workforce, whether it be around demand, and how do we come together as a system to resolve it. And I think actually what we're seeing is primary care moving forward at pace around those ideas and those theories. Clearly change is difficult for everybody, it's difficult for all of us, and it's about them thinking through how that will work differently, particularly when each GP practice will have its own patient population that it's most concerned about. Clearly your GP is going to be more concerned about you than potentially somebody who's living in another part of the county, but it's how we bring those two together, and that's working at the moment, and it's a work in progress that I think we'll see develop much more even over just the coming months, let alone the coming years.
I see we've also got an advert for Health Watch now, so this is good. It's no problem with adverts on this stream. There's a couple of questions about beds in community hospitals, and Martin says, isn't there a need for more beds in community hospitals, and that the hospitals are well placed to be centres of care for those who need it, whether as an in or outpatient? And then a little bit later we have Jane Nicklin say, good to hear details of thinking about around care homes beds. Are there many of these enabling beds across Somerset? Maria, I'm going to go ask you with this one.
Yes, so I think, as we said earlier, there's an absolute recognition that we need some community hospital beds, and we need to be clear about those purposes. But we believe that we can provide more care closer to home with that enabling focus through using care homes. Whereas Alex said, you know, in a community hospital, you can't go and make a cup of tea. You can't go and toast a couple of slices of bread and take them back to where your chair or your bedroom. And actually, we believe that care homes, because they don't have the same restrictions on them that community hospitals do, will be a better place to be able to do some of those re-abling or rehabilitation work. In terms of numbers, I don't actually have the latest numbers. We've increased those during COVID. So we could come back to you and confirm how many beds there are, unless Alex happens to know off the top of her head.
No, I can tell off the top of my head what they are today, I'm afraid. Apologies.
No, that's all right. Here's a new topic, which I think we need to touch, from Graham. To what extent do you see mental health services improving as a result of Fit for My Future? I think that's got to be Alex, hasn't it?
Thanks, David. So mental health was the first work stream, and that was worked on, you know, right from back in 2018, 2019. And what we've seen through that is the development of open mental health. We won Trailblazer money to develop our community mental health services, specifically in Somerset. And so what we have seen in mental health already is a move to increase support base within our communities. So that's around access to things like Mindline, which is now 24/7 and is all age. It's things like workers based within practices who can help to support mental health concerns and escalate up, if that's what we need to mental health teams. So we are already seeing that change. Clearly, there's always a slight lag between the models being developed, the money landing, and actually the recruitment being in place. And people seeing the change on the ground. But certainly within some of our areas, particularly some of our PCNs, we're seeing a significant change in how those supports are provided, and a definite improvement in services, and in particular around access. But that will continue as those Trailblazer monies and that work continues over the next few months. But that almost right at the beginning, I talked about the 4 work streams. Mental health was one of the very first ones to see some of those changes happen, and has been moving forward since that time.
Now I've got one from Robin Horton about the present situation, which everyone understands is not as good as we would want it to be as a result of post-COVID. What about the backlog of elective care, scans, etc.? There is a backlog of 40 months for most interventions and tests. We start at a disadvantage, don't we?
Yeah. Maria, do you want to start? Or
yes, so you know, we've seen that nationally. There is a backlog of elective care, both operations and diagnostics. That's throughout England and UK. We're working hard, and our teams are working hard to address that backlog and to get through it. I'm not sure I recognise a backlog of 40 months for most interventions. That's certainly not something that we see in Somerset. But yes, absolutely recognising that, and with some of the things that we're putting in place are extra diagnostic capacity, thinking about how we work differently. So we're opening up of the diagnostic centre in Taunton will help us address some of that backlog, but also working with other providers to make sure that we use all the facilities in Somerset that we can to get through those scans and operations.
Is anybody able to answer the point from Julie from the Alzheimer's Society about assessments, the backlog in assessments by social workers? And obviously we haven't got the county council here to answer that question directly, but is anybody able to give any sort of answer on that?
Yes, I can talk to that. I form part of the Intermediate Care Board, which looks at a lot of this stuff, and particularly around care packages. And you are right, there is a backlog in terms of assessment for packages. Currently, we do have a social work shortage in Somerset, again, almost as there's happening nationally. But we're working hard. Social workers, like GPs, like physios, take quite a long time to train. So we are working to increase our provision of social workers in the county, and equally are trying to prioritise people who have the greatest need. But I'm really aware, and it comes back to that concern around the carers who've been working so hard during COVID and historically, in terms of how do we help to support them as quickly as possible. So there is work happening around that, a bit like Maria said, around the backlog around elective care, and we will work our way through it. But at the moment, I think it's worth saying, yes, we recognise that, and we are doing everything we can to improve the situation.
There's several ideas that have come up in question, which I won't ask you to respond to immediately, but I think it's well worth us reading through and giving a considered response, because there are different ways of approaching this, and that's what part of this, what this whole process is really about, is finding the best ways of delivering healthcare close to people. I think there's a couple of points which are saying, basically, does this mean a retreat from providing care for people and just leaving people to their own devices? I certainly not the way I read the programme at the moment, but Alex or Maria, would you like to just respond to that? This is really not about leaving people to their own devices, is it? It's about providing care nearer to them in the most appropriate setting.
Absolutely. I'm not sure I can put it any better, David. It's not about, I love working on a programme where actually we're looking at how we improve care. We're not looking about taking money out of care, but we're looking at how do we support a growing, ageing demographic that we know will need support now and into the future. So it's thinking about how do we use our resources best to do that. And yeah, I'm not sure I can put it any better, David.
Thank you very much. I'm afraid we've come to the end of our time. And I think we did most of the questions. There are a few which are not so much questions as points, which we certainly will make sure you have a response to. Can I remind you that this whole session has been recorded, so you'll be able to look on the website and go through it at your leisure, see if there's anything that you missed or you didn't quite understand the response that was given. Please do stay engaged with this, because we're not going to get it right unless we actually hear from people across the county during the process. This is one of the biggest potential changes to the way we deliver care across the county for a long time. And if we get it right, I think we can learn from the experiences of others. We can make sure that we have a better system, better designed for a rural county like Somerset, rather than assuming we all have the same model in every part of the country. And if we can do that right, we can do it more efficiently, and we can make sure better care gets to more people at the right place. So that's what it's all about. Please do keep in touch. Please do continue to let us know your views. If there's anything that on reflection you think, well, I wish I'd said that, do say it. And it will be certainly taken into the system, taken into account, and will be part of our deliberations in future. And we'll get back to you again, not in the foreseeable future, as we move this forward, as we continue the consultation, as we start to try to take some of the right decisions in order to make this literally fit for my future. Thank you very much for your participation this evening. I hope you found it useful. I hope you found it accessible. Good night for now. Bye now.
Well done.